Hi, Miss Nikki here. Welcome to Chapter 11. We're going to talk about axial and appendicular muscles. Please remember that you need to go to Connect and go to APR and look for all of the muscles that are on the list and make sure you can identify them. So just like the skeletal system, the muscles are divided into axial muscles and appendicular muscles. Obviously, axial is going to be head, neck, trunk, and then appendicular muscles are going to be arms and legs, or upper and lower limb, the muscles that are attached to the pectoral and the pelvic girdle. Remember, muscles are attached to the skeleton via tendons. We also have this sheet-like tendon called the aponeurosis, and we'll see some examples as we move through this PowerPoint. So this might be a little confusing. If you've heard of attachment points, you might have heard origin, and it was also mentioned on the last slide, and insertion. I didn't want to talk about it until we got to this slide. Usually origin meant the less movable, and insertion was the movable end of attachment. So again, if you have your tendon attaching to the bone, and then you have your muscle, and then you have another tendon attaching, right? So one of these would be the origin, the less movable, and the other would be the insertion. But these terms here did not always hold true for every muscle, origin and insertion. So now they've kind of relabeled them. So for axial muscles, there's the superior attachment, which is usually more movable, and the inferior attachment, which is usually less movable. And then for appendicular, because remember when we talk about farther or closer to the trunk, we use proximal and distal. Here's a nice image for you. This is our biceps brachii that they've highlighted. They've removed the other muscles so you can just see the biceps brachii. And they're going to show you the proximal attachment, which is on the scapula, and the distal attachment, which is on the radial tuberosity. So what do we mean by movable or not movable? If we flex, right, at the elbow joint, this insertion has to move with your arm. This one, the proximal attachment, stays, it doesn't move anywhere. So this would be the less movable, and this would be the more movable. I'm not worried so much about origin and insertion points. I want you to be able to identify the muscles and have some idea of what their action is, but I'm not going to quiz you on origin and insertions. If you're going into physical therapy, I highly suggest you start learning all the origin and insertions now. You'll just save yourself trouble down the road. We can organize muscle fiber fascicles, and if we organize them in a certain fashion, it's going to lead to specific properties of that muscle. So think about circular. If I arrange the fascicles in a circular shape, they're going to be able to contract and relax and open and close. With parallel muscles, you can see they run parallel, right? All the muscle fiber cells run in the same direction. These parallel have high endurance but low strength. So muscles that you're going to use a lot, you'll see this parallel arrangement. Convergent, you can see that all of the muscle fibers kind of converge on this one attachment point. This gives us a little bit of versatility. You're not putting tons of pressure or force or tension on the tendon. You're kind of spreading it out over the muscle. And then we have this pennant group. So we have unipennant 1, bipennant 2, and then this is 2 or greater. So you can see here's the tendon, and you can see the fascicles are running at a specific angle. It's kind of like an oblique angle. And here they're all running this way. So again, this is kind of converging all the tension on the tendon. So these tend to be a little bit stronger. These are your strong muscles. So muscles work in groups. So it's kind of like coordinated action to make an event happen. And when these muscles work in groups, they each have a function. So the antagonist is the prime mover. It's the muscle that contracts. Then you have the antagonist. That's the muscle that opposes. And if you're opposing contraction, you're doing relaxation. And then the synergist is going to assist the prime mover or the agonist. So they give you examples here, and they're saying if you're trying to go to extension. So you're in flexion, and you're trying to bring your arm back down to its normal position, right? So that would be extension. In that case, this is your tricep brachii. This is one part of your tricep brachii. The rest is kind of hidden back here. Your tricep brachii is the one that initiates the movement. So the tricep brachii is the agonist that is contracting while you lower your arm or do extension. The biceps brachii here, this is your antagonist. Your bicep brachii has to relax in order for you to lift your arm back to extension. If both of these muscles, if the triceps brachii and biceps brachii were both contracting at the same time, your arm wouldn't go anywhere. One has to contract, one has to relax. And then the synergist is going to be your brachialis muscle here in the middle. So you see these work together to carry out a specific function. And if we were doing flexion, they would just work a little bit differently. The brachialis would be the prime mover. So if I was doing flexion, the brachialis would now become the prime mover. The biceps brachii would become the synergist, and doing the opposite would be the triceps brachii. So if you've ever seen somebody work out and they say work your muscles out in antagonistic groups. So if you're doing bicep curls, then the very next exercise to do, it would be tricep extensions. So you're constantly working out the same set of muscles, you're just making them do opposite jobs. So hopefully that made sense. If you have any questions, just email me. Sometimes understanding the criteria for muscle naming will help you learn the names more quickly. So first we have muscles named after muscle action. You can see in this example, flexor digitorum. It probably has something to do with flexion, right? What if you had the term extensor digitorum? Again, it probably has something to do with that action, extension, right? Next, we name them after specific body regions. You can see here rectus femoris. Rectus femoris probably attaches at the femur, right? What about this one? The muscle name is temporalis. It probably sits directly on top of your temporal bone. So these are really nice. Muscle attachments, third kind of criteria used. So this is a great one, sternocleido or clidomastoid. So this muscle attaches at the sternum, the clavicle, and the mastoid process of the occipital bone. So that's why it's called sternocleidomastoideus or mastoid. You can use either ending, and you'll see that in the lab book. The fourth criteria, the orientation of muscle fibers. So sometimes we're going to name them not only for the location, the body region, but also for the muscle fascicle arrangement. So rectus means straight. So rectus abdominis, straight abdominal muscle fibers. What do you think rectus femoris? Again, straight muscle fibers on the femur. Continuing on this trend, we have muscle shape. So our deltoid is shaped like a triangle. Sometimes we'll use the word longus for long, or we'll use brevis for short. Next, we name them sometimes after muscle size. So we have a gluteus maximus. That's one of the largest muscles of the buttocks or backside. There's also a gluteus minimus. It's probably the smallest gluteal muscle, right? And then last, sometimes named after the muscle heads. And we saw this with triceps brachii and with biceps brachii. So this is why you can't just say triceps. Triceps just means three-headed. Well, three-headed what? Brachii is telling you the region, the arm, right? The brachial region. So make sure when you're writing your answers out, you have to write out triceps brachii, biceps brachii. I think it's important to look at this clinical view and intramuscular injections. So why would we want to administer medication directly into the muscle? If you remember, muscles are highly vascularized. So this is good, right? We can get the medication directly into the cardiovascular system via the muscle's blood vessels. We can give a large amount of medication at one time. It'll slowly travel and uniformly travel into the bloodstream. And this is how we administer vaccines, some contraceptive medications, antibiotics, and the common sites are going to be the shoulder, deltoid, gluteal, buttocks, or quadriceps, or on the anterior portion of the upper thigh. For the next few slides, I'm going to go over kind of muscle location. I want you guys to take a look at the list of all the muscles that we have to know, the 50 or so, and then go to APR and make sure that you look at every single muscle. Sometimes we have superficial views versus deep views. You can see that this muscle figure has been divided in half, and these muscles are on top of these muscles. So sometimes when you're looking at a figure, you may not be able to see the muscle because there are other tendons or muscles on top of them. So this is a good example. The buccinator or buccinator, it would be under here. We cannot see it unless we pull away or dissect some of the other muscles. So sometimes you might only see a tiny little section of a muscle if all of the muscles are on top of. If you're looking at a superficial view, you might not be able to see the muscle at all, or you might only be able to see a tiny section of the muscle. So it makes it a little confusing. So please utilize the APR. It will help, I promise. Here we have this term epicranius. Epicranius is actually made up of the frontalis muscle. So this is frontalis. Here's that broad tendon sheet, the aponeurosis. And then in the back here, obviously we can't see it because we're looking at an anterior view, there would be the occipitalis muscle. So sometimes they refer to all three of those as epicranius because they're all connected via that aponeurosis. You can see here orbicularis oculi. Please pay attention that it's orb. A lot of people will do this, and that is not right. So orbicularis oculi, it's a circular muscle around the eye, just like orbicularis oris is a circular muscle around the mouth. We can also see the platysma, this really thin sheet here that covers the neck muscles. We can also see the zygomaticus. You do not have to differentiate between major and minor. If you just call this group of muscles zygomaticus, I'm okay with that. We also have nasalis, which is here on the bridge of the nose. And I'll show you on the next slide the masseter and the buccinator or buccinator. You can also see in this deep view the sternocleidomastoideus. So remember, it comes up and it attaches to the mastoid process of the occipital bone and then comes down to the sternum and to the clavicle. But the platysma would be sitting directly on top of the sternocleidomastoid. Here we have a nice lateral view. You can see a little bit better the temporalis. Remember, the temporalis sits directly over the temporal bone. Again, you can see a better view of the occipital belly and the frontal belly, so frontalis, occipitalis, and that aponeurosis sheet. You can also see a little bit better the attachment point, the mastoid process of the occipital bone, attachment point for the sternocleidomastoideus. We also have the masseter. This is responsible for chewing. And then we also have the buccinator. And this is what I meant by you have to be careful. We removed the rhizoris and some other muscles. Really, this is all you can see, two little pieces of the buccinator or buccinator. Remember this, if you maybe remember, we said buccal cavity, but we also called it the oral cavity. So buccal means mouth, so you can see that this was named for the region that it's located, the buccinator or buccinator. Textbook does a nice job of talking about specific actions and then which muscles are necessary for that action to take place. So mastication would be chewing, and the two muscles we're going to focus on are the masseter and the temporalis. So the temporalis elevates and retracts the mandible, and the masseter also elevates but protracts the mandible. So if you remember, you need elevation, depression, protraction, and retraction in order to do this action, mastication or chewing. Here's a nice image of the sternocleidomastoid in a lateral view. And in the textbook, they talk about whether both are contracting, so bilateral. If you do bilateral, both sides contracting, that flexes the head. And then if you do unilateral, so just one-sided, you can do this lateral rotation, and that's due to the sternocleidomastoid muscle. And remember, it attaches to the sternum and the clavicle and the mastoid process of the occipital bone. I wanted to show kind of the complexity with this image and realize that sometimes we can have multiple layers. It's not just that we have a superficial layer and a deep layer. We could have superficial, deep, and deeper. So here, the trapezius has been removed. That was the superficial. Then on this side, they're showing you the deep layer, and then they're showing you an even deeper layer if we retract or cut these sections of muscle. So there's a lot of complexity here. We have hundreds of muscles, and we are covering 50. So we're kind of sticking to mostly superficial muscles here. Now we move on to the muscles of respiration. We know this as breathing. So here we have the external intercostals and the internal intercostals, and then the diaphragm that we'll see on the next slide. Here the external intercostals stop just before the costal cartilage here. And these external intercostals are going to expand out if you're taking in a breath. So if you're doing inspiration, bringing air in, these external intercostals are going to flare out. And if you're doing expiration, so blowing air out, these internal intercostals are going to contract. And you can see the internals come all the way to the sternum. Also important for breathing is the diaphragm. We saw on the previous image from the anterior view this kind of umbrella-shaped muscle. This is an inferior view. You're looking from the underside. So the whole point of the diaphragm is when you're breathing in, when you're doing inspiration, so you're breathing air in, the diaphragm is pulled down to allow air in. And then when you're exhaling, the diaphragm snaps back up to its original position. We'll talk more about this when we get to the respiratory chapter, and we'll talk about the mechanisms specifically for breathing, but you should know the muscles that are responsible for this action. Now we're going to look at abdominal wall muscles. So here we have transverse abdominis, rectus abdominis, internal oblique, and external oblique. So we'll do rectus abdominis first. Rectus means straight abdominal muscles. Then we have external obliques. You can see this side is deeper. They've cut away the external. So here's the external obliques, and they go all the way up to the serratus anterior, which we also have to know, and the pectoralis major. Then it's kind of the next level is going to be the internal obliques. So the internal obliques are here, and they stop at the bottom of the rib cage. And then eventually we get to the transverse abdominis. And the transverse abdominis would be very deep to the rest of these, and it would run in a transverse fascicle arrangement. So real quick, just looking at all of those, you have the rectus abdominis, the transverse abdominis, you have the external oblique, and then you have the internal oblique. And you'd have external obliques on top of that, right? So there's 4 muscles and 4 different muscle fascicle arrangements that are providing support in the abdominal area. So having a strong core is having muscle tone in all 4 of these abdominal muscles. This elevates your chest, right? Allows for better circulation, not only in the thoracic cavity, but in the abdominal cavity as well. So also, you can see here in this image, I wanted to show you the transverse, and the transverse are running deep to all of the other muscles. So that I like here, they kind of are showing you layers. So think of the first layer, it's the external oblique. You also have this aponeurosis, this tendon sheet of the external oblique. So this is kind of like layer 1. And then we move to layer 2. If I pulled away the external oblique, what are the next muscles that we'd see? So now here we can see the rectus abdominis and we can see the internal obliques. And the third layer would be the transverse abdominis, and those muscle fibers would be running kind of east to west here. For abdominal wall muscle actions, we kind of have all of these cooperating with flexion at the torso. So if I want to bend over and pick something up, if I want to bend at the waistline, that flexion of the torso is what they call bilateral action. So both sides are working for you to flex or bend over. If we have external, internal, and transversalis, if we have all three of those working unilaterally, so just one side, all three of those are working, that allows us to kind of form that C curve or bend laterally to one side or the other. We're only going to discuss one group of muscles in the pelvic floor, and that collective group is known as levator ani. And you can tell from that term that it's probably going to elevate the anus. So this group of muscles basically acts as support for the pelvic organs, and one of the three muscles in this levator ani group has to relax in order for defecation to occur. Looking at the muscles that move the pectoral girdle, the ones we're going to focus on are the pectoralis minor. So the pectoralis minor is deep to the pectoralis major. So the pectoralis minor is going to depress the scapula. So move the scapula down. You can see it's attached here and again at ribs 3, 4, and 5. Also the serratus anterior. Serratus anterior here, it's named because it looks like a serrated knife edge when all of the muscles are together, right? Remember, the external obliques are going to come up and meet the serratus anterior. But the serratus anterior is going to stabilize the scapula, kind of keep the scapula in place. And then it also aids in abduction or abduction. If you move the arm out, the serratus anterior is aiding in that movement. On the posterior side, the muscle we're going to look at that moves the pectoral girdle is the trapezius. You can see that one of the attachment points for the trapezius is the spine on the posterior surface of the scapula. And really, this muscle does quite a bit. It can elevate the scapula, it can depress the scapula. Think of kind of shrugging your shoulders, and this is the muscle that's responsible. We're going to use the same anterior image to look at the glenohumeral joint, right? So your shoulder joint here. The muscle we're going to look at is the pectoralis major. So the pectoralis major allows you to flex at this shoulder joint. So lift this arm straight forward, kind of raise the arm at the shoulder. And it also helps if you're bringing the arm back down, if you're adducting the arm. The deltoid here, this triangular shaped muscle that makes up your shoulder, this also helps when you're flexing the arm or raising the arm. And it also does the lateral and medial movement at this joint. So turning the arm outward laterally or turning the arm medially, that's done at the deltoid. It also aids in adduction. Remember, we have agonists and synergists that kind of aid in some of these muscle actions. On the posterior side, we're going to focus on the latissimus dorsi. So you can see it's this really broad fan-shaped muscle, and we usually think of a swimmer's stroke to describe what's going on or what the action is at the latissimus dorsi. So this muscle allows you to throw the arm forward, so extend the arm, and then to bring the arm back down, adduct, and then also you're kind of rotating the arm medially when you do that swimmer's stroke. We're not going to cover these other muscles, but if you're interested in sports medicine or physical therapy, there's a great image in the book, and it's kind of showing you where the supraspinatus and the infraspinatus come in if you're throwing out a pitch. So that might be interesting to you. Make sure you take a look at that in the textbook. We're moving on to muscles that move the elbow joint. So we're here at the elbow. We're going to look at three muscles: biceps brachii, brachialis, and brachioradialis. All three of these are going to help us flex at the elbow joint, so to lift the forearm up. We've seen the biceps brachii already. It's attached here to the scapula and to the radius at the radial tuberosity, one of the features we learned back in the skeletal system. The brachialis would be directly underneath the biceps brachii. If you remember when we talked about muscle action groups, we said that one's usually the agonist and the other is the synergist or the aid or helper. We can see that the brachialis attaches here at the ulna. The third, brachioradialis, I don't have a better image for you, but the brachioradialis attaches at the humerus, and then distally it attaches at the styloid process of the radius. Again, all three of these aid in flexion at the elbow joint. So then if we want to talk about extension, the muscle that we're really going to talk about is triceps brachii. There are others, but this is the one we're focusing on. So triceps brachii is three-headed. You can see one head, two heads, and then if we removed these, you could see the third. It kind of runs up and under, so it's not as easily visible. And the triceps brachii are going to aid in extension or bringing the arm back to its normal position after flexion. For the forearm muscles, we're going to focus on the supinator and the pronator teres. So remember, supinate was holding your hand open like you're going to hold a bowl of soup, and pronator teres is when you cross the radius over the ulna and we see the back of the hand. So here is the pronator. So this is pronator teres, and supinator is this muscle here. And probably the best way to think about these are their locations or attachments to the humerus. So the supinator is on the thumb side. So it's attached to the lateral epicondyle of the humerus. The pronator, P pronator, is on the pinky side. So it's attached to the medial epicondyle of the humerus. I wanted real quickly to point out that the anterior forearm muscles all usually have a flexor in front of them. So we're looking at anatomical position, palms facing forward. So the anterior forearm is responsible for flexion. So if I flex at the wrist, these muscles are responsible for that flexion. And what's nice is the naming kind of gives you an idea of the attachment points. So think about flexor carpi ulnaris. It must attach somewhere at the carpal and then somewhere at the ulna. So one of the questions that I'll ask you is not specifically where's the flexor carpi ulnaris. I would say, where would you find a flexor on the forearm? Would it be on the anterior side? Yes. So what do you think about the posterior forearm? If I do pronation, and now the palm of my hand is facing posteriorly and the back of my hand is facing forward, if I'm looking at these posterior forearm muscles, they're probably all responsible for extension, right? So they're going to have the word extensor in them. So again, my questions are more going to be related to if I told you that the patient has damage to their extensor digitorum, where are you going to look on the forearm? Posterior or anterior? So anytime you see extensor, you should be thinking posterior. And if you see flexor, you should be thinking anterior. When it comes to the forearm, you'll see it's different for the lower leg. When studying the leg muscles or the lower limb muscles, there's kind of two approaches to learning. One, you can look at location and kind of list all the muscles that are on the anterior thigh. And then there's also action. So are they doing flexion? Are they doing rotation or extension? And where? Is it at the hip joint or is it at the knee joint, right? So if we look at location first, we're at the anterior thigh. And most of us, if we think about the anterior thigh, we think of the quads. So there's four muscles here. There's the rectus femoris, straight on the femur. There's the vastus lateralis, it's on the lateral side. We have the vastus medialis, it's on the medial side. And then deep, or inferior to the rectus femoris, we have the vastus intermedius. So those are the four muscles that make up the bulk of the anterior thigh. Their function, if you wanted to look at action, the majority of what they do is flex or allow for flexion at the hip joint. So basically, if you're standing here, allowing you to lift your leg straight out at the hip joint. Here's a better look at the adductors. We actually have 3 adductors. We like to just collectively call them adductors. If you're going into physical therapy or physical therapy assistant, then you might want to learn them individually. That's fine. You can see the brevis is really small, and then there's the longus, and you cannot see all of the magnus. It actually spans behind or is deep to the anterior longus. And then the gracilis here, here's another look at this muscle. So a lot of people think of the gracilis as being more medial. It's the inside thigh muscle, and then the adductors are more lateral. Another muscle we need to talk about is the sartorius here. The sartorius kind of aids the quads. The sartorius is also going to help flex the thigh. It's also going to help with lateral rotation. You can see here, this is one of the longest muscles because it attaches, its proximal attachment is up here at the ilium, and its distal attachment is at the tibial tuberosity. This is also the muscle that's responsible if you're sitting on the ground and you have your legs kind of crossed in front of you. So they used to call it Indian style. I think now it's crisscross applesauce, but this is the muscle that's responsible for that action. Next, we move on to some of these lateral and medial thigh muscles. Here we have the tensor fasciae lati. It's responsible for abduction. And if you remember abduction at the hip joint, moving the leg away from the midline. And then we have adductors and gracilis, and they're both responsible for adduction, bringing the leg back to midline, right? They can also help with rotation. So the adductors over here are going to help with lateral rotation of the leg, and the abductors are going to help with medial rotation of the leg. Now we move on to the posterior hip area, and we look at the 3 gluteal muscles. There's only 2 listed here, but there are 3. Deep to the gluteus medius is the gluteus minimus. All 3 of these muscles are going to help us extend the thigh. They're going to help us with medial rotation, and they're also going to help us with abduction. Another interesting fact about gluteal muscles, if you run a lot, you'll see well-defined gluteal muscles. And this is because you have to kind of have a counterbalance. When you're running, you're propelling yourself forward and you have this tendency to lean kind of forward a little bit. So the more you work those gluteal muscles, the stronger they get, and it's to kind of counterbalance you while you're running. Now we move on to posterior thigh muscles. We need to talk about hamstrings. These are 3 muscles, the semimembranous, the semitendinosus, and the biceps femoris. So you can see that it is 2-headed from that term biceps, right? Don't get this confused with rectus femoris. So rectus femoris is on the front, biceps femoris is on the back. These hamstring muscles, if we look at them in terms of function, it's kind of interesting because all of their proximal attachment points are up here on the ischial tuberosity. So that's why we had to learn about that feature on the coxal bone. So all of the hamstrings attach at the ischial tuberosity. They're going to aid in hip movements or hip action. So flexing of the entire leg at the hip joint, they kind of aid in that. But their main job is to do flexion of the lower leg. So they help flex at the knee joint. Imagine kicking your heel up to your gluteal muscles. All of these hamstrings are aiding in that movement. The biceps femoris is going to have also a lateral movement. So the ability to turn your leg outward position would be biceps femoris. And then these two, the semis, they aid in medial rotation. What I would like you to notice is that the semi-T tendinosus sits on top of the semi-membranosus. So let me see if I can draw here over so we can see this muscle right here. This is the semitendinosus, T. What color do I want? Let's try orange. This muscle that I'm outlining is the membranosus. So the tendinosus sits directly on top of the membranosus. This can be confusing for people. If you just take a quick glance at it, it's kind of hard to tell which side is the bicep femoris two-headed muscle, and then which side is the semitendinosus and semimembranosus. So the way that I usually think about it, the semitendinosus and the semimembranosus are always medial. The biceps femoris, that's the lateral muscle. Finally, we move on to the lower leg. I like this lateral image. I like to move through the muscles in a kind of an orderly fashion from posterior to anterior. Here we have the gastrocnemius, then we have the soleus, then we have the fibularis longus, then we have an example of an extensor, and then we have the tibialis anterior. So the gastrocnemius is what flexes the lower leg, right? Again, if you're bringing your heel to your gluteal muscles, your gastrocnemius is working. Also, the soleus is going to do plantar flexion. Up on your tippy toes, the soleus is going to help with that. Your fibularis longus is going to evert the foot. Remember eversion and inversion? And then we have the tibialis anterior, which is going to dorsiflex, so that's heel strike, and it's also going to aid in inverting the foot. Here's a posterior view so that you can see the two-headed nature of the gastrocnemius or calf muscle. You can see the soleus is peeking out from behind the calcanean tendon, which is attached at the calcaneus or the heel bone. Also, if we do a deep view, if we remove those muscles, I wanted you to see flexor, flexor. So on this, for the lower leg, the flexors are on the posterior side. Remember how in the forearm, the flexors were on the anterior side. So, where do you think the extensors are for the lower leg? If flexors are on the posterior side, that means extensors are on the anterior side. How is that different than the forearm? On the forearm, where did you find extensors? You found them on the posterior side of the forearm. So this is what I meant earlier by it's the opposite when we're talking about forearm versus lower leg. This is it for my lecture. Please make sure you go and view all of these muscles and that you take the practice quiz as many times as you can to really learn the location and have all these muscle names just kind of come to you. You see the image and you start typing. It'll really help with the test, I promise.